Hello everyone, my name is Felicia and
My name is THIVASHINIE.
today we are going to present about Paroxysmal Nocturnal Hemoglobinuria. So for the introduction, Paroxysmal Nocturnal Hemoglobinuria, which is also known as PNH, is a rare acquired life-threatening disease of the blood. The disease is characterized by destruction of red blood cell, which is hemolytic anemia, blood clots, which is thrombosis, and impaired bone marrow function. Doctors call this breaking apart hemolysis. PNH is primarily a disease of younger adults. The median age of diagnosis is 35 to 40 years of age, with occasional cases diagnosed in childhood or adolescence. PNH results in the death of approximately 50% of the affected individuals due to thrombotic complications and until recently had no specific therapy. PNH is closely related to aplastic anemia. The median survival after diagnosis is 10 years. However, some patients can survive for decades with only minor symptoms. PNH occurs when mutation of a gene called PIGA occur in a bone marrow stem cell. Stem cells give rise to all the mature blood elements including red blood cells which carry oxygen to our tissues, white blood cells which fight infection, and platelets which are involved in forming blood clots. In PNH, the affected stem cell passes the PIGA mutation to all cells derived from the abnormal stem cell. Cells harboring PIGA mutations are deficient in a class of proteins called GPI-anchored proteins. Certain GPI-anchored proteins protect red blood cells from destruction. Some are involved in blood clotting and others are involved in fighting infection. The majority of PNH-related issues including disruption of red blood cells, blood clots, and infection result from a deficiency of these proteins. The genetic defect responsible for causing PNH has been identified. Knowledge of the genetic defect will allow researchers to study the disease in a manner that was not previously possible and may give insight for developing more effective therapies. Now, I'll pass it on to Devashini.
Okay, now I will explain about the etiology. There's two factors are necessary for the development of PNH. An acquired somatic mutation of the PIGA gene, which affects one or more hematopoietic stem cells, creating defective PNH blood cells, and a process that leads to the multiplication and expansion of these defective stem cells. Most likely, PNH arises in the setting of expansion of these defective stem cells. Most likely, PNH arises in the settings of autoimmune bone marrow failure. Researchers believe that defective PNH stem cells survive the misguided attack by the immune system and multiply, while healthy stem cells are destroyed, resulting in the development of PNH. The mutation in the PIGA gene is a somatic mutation, which means that it occurs after conception. It is not inherited and is not passed on to children. This mutation occurs randomly. In PNH, this mutation occurs in a single hematopoietic stem cells, which then multiplies and expands. Researchers believe that other factors such as secondary gene mutation or immune factors are necessary for PNH cells that expands and multiplies. Therefore, although the PIGA mutation is necessary for the development of PNH, it presents alone is not sufficient to cause this disorder. In a few cases, this additional factor has been shown to be a second somatic mutation that endows the mutant cell with a growth advantage. The PIGA gene produces a protein that is essential to the creation of GPI anchors. These anchors allow some proteins to attach to a cell's membrane. These proteins are called GPI anchored proteins. In cells with anchored proteins cannot attach to the cell's membrane. Some of these GPI anchored proteins serve to protect cell from the immune system. Consequently, a lack of these surface proteins renders P and H blood cells extremely susceptible to destruction by a part of the immune system known as the complement system. P and H red blood cells are particularly sensitive to premature destruction of the complement system. The complement system is a complex group of proteins that work together to fight infection in our body. These proteins respond to bacteria, viruses, or other foreign substances in the body. They work with white blood cells to destroy foreign materials. In individuals with P and H, the complement system mistakenly destroys P and H blood cells due to the lack of GPI anchored proteins that normally protect blood cells from the activity of the complement system. So now I will pass it to Felicia.
Okay, so now I'm gonna talk about pathogenesis. There are three processes on how P and H develops. The first one is hemolytic anemia. This leads to pneumochromic normocytic anemia, chronic intravascular hemolysis, and jaundice, which will be visible in the white of the eyes. We also can see bone marrow suppression, which leads to pancytopenia, where patients will lose their ability to make red blood cells, white blood cells, and platelets. Lastly, the aspect that often goes unrecognized is the arterial and venomous thrombi, which is due to complement activation of blood cells, and also abdominal or cerebral veins will be affected. As you can see, these are some examples of how jaundice would look like. I'll pass it on to Divashini.
Okay, now I will explain about the symptoms and sign and symptoms of this disease. The symptoms of P and H occurs because of the production of defective blood cells and because the bone marrow does not produce enough blood cells. The specific symptoms and progression of the disorder vary greatly from one person to another. The premature destruction of red blood cells is the primary clinical finding associated with P and H. Hemolysis may result in hemoglobin in the urine, although many individuals with hemolysis do not have visible hemoglobin in their urine. When hemolysis occurs, a red blood cell's outer wall breaks down, releasing hemoglobin. Hemoglobin is excreted from the body in the urine, resulting in the dark colored or blood colored urine that is characteristic of this disorder. Hemolysis is ongoing but may worsen during periods of infection, trauma, or stress. The premature destruction of red blood cells may result in low levels of circulating red blood cell that is made worse by the underlying bone marrow dysfunction. Mild hemolysis can cause fatigue, rapid heartbeat, headaches, chest pain, and difficulty breathing when they exercise. If hemolysis is severe, additional symptoms can develop, including disabling fatigue, difficulty in swallowing, and painful contraction that affect the abdomen, the esophagus, and in men can cause erectile dysfunction. Chronic hemolysis can also lead to the development of blood clots, and some affected individuals may develop acute and chronic kidney disease. In addition to red blood cells, defective hematopoietic stem cells may also produce defective platelets. Some researchers believe that these defective platelets are abnormally prone to form blood clots. Chronic hemolysis may also contribute to the development of blood clots. Blood clots can be carried via the bloodstream to various areas of the body, potentially resulting in life-threatening complications. All patients with PNH have some degree of bone marrow dysfunction. Individuals with mild bone marrow dysfunction may not have any symptoms or only mild symptoms. Individuals with severe bone marrow dysfunction may have low level of red and white blood cells and platelets. Red blood cells deliver oxygen to the body. White blood cells help in fighting off infection, and platelets allow the body to form clots to stop bleeding. A low level of circulating red blood cell is also known as anemia. A low level of white blood cell is known as leukopenia. A low level of platelet is known as thrombocytopenia. Individuals with anemia may experience tiredness, increased need for sleep, weakness, lightheadedness, dizziness, pale skin color, difficulty in breathing, and cardiac symptoms, including chest pain. It is important to take note that affected individuals may not have all of these symptoms discussed above. Affected individuals should take to their physician and medical team about their specific case, associate symptoms, and overall prognosis. So now I will pass it to Felicia.
Okay, so now I will talk about the general and advanced lab diagnosis for PNH. Lab diagnosis is usually made based on thorough clinical evaluation, detailed patient history, and variety of specialized tests. There are two different tests for PNH. The first one is flow cytometry, which is used to detect the absence of glycosphatidyl inositol, which is a GPI-linked protein expression on granulocyte and monocyte surfaces. The second test that is done for diagnosis is the HEM test, which is also known as acidified serum lysis test, establishes the diagnosis of PNH, demonstrating a characteristic abnormality of PNH red blood cells by acidified fresh normal serum. I will pass it on. Okay, so this is the example of HAM test. So as you can see, the first one is erythrocytes of a patient with PNH, and the second one is erythrocyte of a healthy donor. So there are three serums. The first one is intact serum, the second one is acidified serum, the third one is heat and inactivated serum. As you can see, for PNH patient, the acidified serum turned from yellow to red. It indicates that that person has PNH. I will pass it on to THIVASHINIE.
Okay. Now I will explain about the common and advanced treatment. The common treatment used for PNH is the drug exolizumab, also known as Soliris. It is a humanized monoclonal antibody that attaches to blood proteins that kill red blood cells. In PNH patients, the medication lowers the risk of thrombosis and can enhance quality of life. The next common treatment used is bone marrow transplantation, where it destroys P and H clones in patients. Some of the advanced treatment used for P and H are Empaveli injection, which is also known as mexacoplin, Robolizumab, CWVZ, also known as Ultomiris, and Danicopan. This prevents C3 from splitting into C3A and C3B, helping to stop intravascular hemolysis and extravascular hemolysis. The Ultomiris works by blocking the body's destruction of red blood cells, while danicopan is a small molecule inhibitor of complement factor D. So that's all from me. I will pass it to Felicia.
So now I'll be talking about new research on PNH. So FDA approves the use of pegcetacoplan injection, but it is only available through a restricted program under risk evaluation and mitigation strategy with his programs. Pegcetacoplan is the first PNH therapy to attach protein C3 and complement it. At the start of the study, the average hemoglobin level was 8.7 gram per deciliter. Patients in the pegcetacoplan group had an average hemoglobin rise of 2.4 gram per deciliter after 16 weeks, while patients in the eculizumab group had an average hemoglobin drop of 1.5 gram per deciliter. This shows that pegcetacoplan is more effective than eculizumab. However, pegcetacoplan has its side effects and it should be only used under medical professionals' advice and under strict medical evaluation. So this is a picture of Empaveli, which is pegcetacoplan injection.
Okay, now I will conclude it. Paroxysmal nocturnal hemoglobinuria, which is also known as PNH, is a rare disorder that causes red blood cells to break down sooner than they should. This early destruction can lead to symptoms and complications that range from minimal, such as decolorization of urine, to severe, such as leukemia and stroke. There are no known risk factors of PNH. This condition involves a gene called PIGA, but it's not a disease you can inherit from your parents. The disease is acquired through a genetic mutation that occur throughout your life. PNH occurs when mutation leads to the loss of the PIGA gene. The mutation happen in what are called hematopoietic stem cells. These are the cells in your bone marrow that lead to the production of blood cells. If you have developed a mutation, then you will create abnormal blood cells. The loss of the PIGA gene means that you lack a protective protein layer on the outside of your red blood cells. In normal cells, this layer of protein signals to your immune system that the red blood cells aren't foreign and shouldn't be destroyed. When you lack these proteins, your immune system breaks apart your red blood cells. If you have PNH, you may have less blood platelets, which are responsible for blood clotting. It's also likely your platelets will have impaired functioning. Hence, patients who have symptoms of PNH, as stated above, should immediately consult medication before it becomes worse. This is the reference we used for for this presentation. That's all from us. Thank you.
Thank you.